Hello everyone and welcome to our module on vaccination. Let's start by talking about the different types of vaccines, because if you understand how the different types of vaccines work, then it's easier to remember and to understand why some vaccines are safer than others. When you're trying to vaccinate against a bacterial infection, most vaccines fall into one of two categories. The first category is a toxoid vaccine. These vaccines are made up of chemically modified protein toxins. Basically, the toxin from the bacteria is modified slightly so that it cannot cause infection, in other words, so that it's non-toxic, but that it still elicits a strong immune response against the toxin that's normally produced by the bacteria. And some examples of toxoid vaccines include the vaccines against tetanus and diphtheria, and these are very, very safe vaccines because they're incapable of causing infection by themselves. They're just proteins, but they're a special kind of protein designed to elicit an immune response from the body so that the bacteria cannot cause infection. Some other bacterial vaccines are called conjugate vaccines. These vaccines are designed to create antibodies against a bacterial polysaccharide, but the problem is that polysaccharides are sugars, and sugars generate a very weak immune response. So to get around this problem, conjugate vaccines conjugate or bind the polysaccharide to a protein that is highly immunogenic. For example, tetanus toxoid is often used. And the idea here is that the protein, the tetanus toxoid, will stimulate the T cells in the immune system, but antibodies will be produced against the polysaccharide, which is found in the bacteria, and therefore you will have antibodies against that bacteria. And an example of a conjugate vaccine is the vaccine for Haemophilus influenza type B, which we'll talk about later in this video. There are two types of viral vaccines that we administer in the United States. One type is called a killed or inactivated vaccine. The other is a live attenuated vaccine. Killed or inactivated viral vaccines contain a virus that has been killed or inactivated by a chemical. Because of this, the virus cannot replicate and therefore it cannot cause disease. And there are many examples of killed viral vaccines. Some polio vaccines are made in this way, so is the vaccine for Hepatitis A, the shot that's used for influenza, and the rabies vaccine. And because these all have killed versions of the virus, they can be used in immunocompromised people because they are incapable of causing an infection themselves. In contrast, live attenuated viral vaccines contained weakened viral particles. They replicate inside the body, but they do so poorly. And the idea here is that you want them to replicate a little bit to generate an immune response, but not so much that they cause symptoms of infection. And the three major vaccines that are made up of live attenuated viral particles are the MMR vaccine, the Varicella vaccine, and the Rotavirus vaccine. And we'll talk about all of these later in this video. There are some other live attenuated vaccines, but they're not used very frequently. The oral version of the polio vaccine is a live attenuated virus, and the intranasal influenza vaccine is also a live attenuated virus. The thing you need to remember about live attenuated viral vaccines is that they can potentially cause an infection, so it's not safe to give these to immunocompromised patients. They are also not used in pregnancy because of the potential to cause infection in the baby. And the mnemonic I've always used, and the one that I was taught to remember which vaccines are alive, is that the R's are alive. MMR, Varicella, and Rotavirus. Each of these vaccines has an R in its name. Let's talk about the valence of different vaccines. Vaccines that are monovalent protect against a single strain or single pathogen. In contrast, vaccines that are polyvalent protect against two or more different strains or pathogens. So for example, we'll talk about some vaccines later in this video that are divalent, meaning they are effective against two strains of a virus or bacteria. Others are trivalent and others are quadrivalent. Let's talk about contraindications and precautions for vaccines. Really, the only contraindication to receiving a vaccine is if a patient has had a prior severe allergic reaction to the same vaccine. Many vaccines are given multiple times. They're given as an initial dose and a booster dose. And if a patient has a severe allergy to the initial dose, then often you will not give the booster dose. That's really the only major contraindication for most vaccines. There is a precaution about vaccines. If a child has a moderate to severe febrile illness, sometimes we will hold off on vaccinating the child at that time. The reason is because if the illness gets worse or the fever spikes, we won't know whether it's the underlying infection or whether it's the vaccine causing the problem. But in general, even children who have a mild febrile illness can be vaccinated, and usually it's more dangerous to not vaccinate them and risk them potentially never getting vaccinated than to vaccinate them in the setting of a mild febrile illness. And then finally, let me tell you one basic principle of how vaccines work, and this will help you understand the schedule of when we give vaccines to children. So immunizations before 6 weeks of age in a newborn baby have a very weak response. So in general, we try not to vaccinate children before 6 weeks unless we really have to. There's only one vaccine we give before 6 weeks, and that's hepatitis B. The magnitude of an antibody response to a vaccine is higher the older the child is at the age of the first dose. So ideally, we would wait until children are 5 or 6 or 10 years old to vaccinate them because their immune system is strong enough at that point to generate lots of antibodies. Unfortunately, if we wait that long, lots of babies and little children will get sick before they're vaccinated. So we have to vaccinate little babies, but when we do that, we often have to give them multiple doses because one dose isn't enough because they don't generate a very strong antibody response. And this is the reason why there are so many vaccines that we give to babies at 2, 4, 6, and 8 months. It's because we have to give them lots of doses to get a good antibody response. Shown on this slide is the pediatric vaccination schedule. Down the column here are the names of the different vaccines that children receive, and along the top are the ages at which they need to receive them. And this chart often strikes fear in medical students. It can be very intimidating, but I'm going to give you my system for remembering it. So in order to remember this chart, you need to appreciate that you can break all these different vaccines down into 4 groups. This group down here at the bottom is really in a class by itself. Influenza vaccine is given every year to children and adults, and these other vaccines are all given to older children, children above 10 years of age. So really this group is in a class by itself. These ones at the top are given to babies and small children. You can break them down into 3 groups. The first group is just hepatitis B. That's the only vaccine given at birth, and we'll talk about the reasons why that's the case in just a minute. The second group are these vaccines right here, MMR, Varicella, and Hep A. I call them the 1-year vaccines because they're all given for the first time at 12 months of age. And so if you separate out hepatitis B given at birth and the 1-year vaccines given at 12 months, then all the other vaccines fall in this big group here. This is the bulk of vaccinations for children. All of these vaccines are given at 2, 4, and 6 months of age, plus boosters later on in life. So let's start by talking about hepatitis B vaccine. It is a recombinant vaccine, and what this means is that it's made up of hepatitis B surface antigen. It's a protein vaccine, but the vaccine is produced through recombinant DNA, which is inserted into yeast cells. But basically it works like a toxoid vaccine. It's just a protein. It's not dangerous in and of itself. It's the only vaccine given in the first 24 hours of life, and the reason for this is that potentially a mother who has hepatitis B can pass the infection on to the baby, and newborns who acquire the infection in this way from their mother almost always develop chronic hepatitis B and go on to develop cirrhosis. So for this reason, we give the hepatitis B vaccine at birth, followed by a booster dose at 1 month and 6 months. And the way you can remember that this vaccine is given at birth is that hepatitis B is for newborn babies. That's the way I've always remembered it. There is one special situation regarding hepatitis B, and that's when the mother is known to have chronic hepatitis B and to be Hep B positive. In that situation, you still vaccinate the baby at birth, but you also administer hepatitis B immune globulin. And the idea here is that babies born to mothers who have chronic hepatitis B are at very high risk for catching the infection from their mother, so you give them immunoglobulin at birth for passive immunization and the vaccine for active immunization. So back to this chart. Now we've talked about hepatitis B, the only vaccine given at birth. Now we're going to talk about these 3 vaccines, which are all given for the first time at 12 months of age or a year old. For all the 1-year vaccines, you have to wait until 12 months of age in order to avoid having the vaccine become neutralized by maternal antibodies. Mothers can have antibodies that they can pass to the baby that can neutralize these vaccines, but those antibodies in the baby disappear by about 6 to 9 months of age. And so if you wait till 1 year, then you can give the vaccines and they will work. If you were to give these vaccines before 1 year at an earlier age, there's a high risk that the vaccine would fail because of the maternal antibodies. You can remember the 1-year vaccines by the mnemonic MVA1. The M is for measles, mumps, and rubella, which is often called the MMR vaccine. The V is for varicella, and the A is for hepatitis A. The MMR vaccine is a live attenuated virus vaccine. It contains attenuated viral particles for the viruses that cause measles, mumps, and rubella. Mumps causes parotid swelling, like what this child has here in this picture, as well as other symptoms, and measles and rubella both cause a maculopapular rash like this child shown here. And because the vaccines for measles, mumps, and rubella are all given on the same schedule, years ago they were combined into a single vaccine, the MMR vaccine, to decrease the number of shots required to give the child. The varicella vaccine prevents chickenpox. This is a picture of a boy with chickenpox on the screen here. Chickenpox causes a diffuse vesicular rash that is very, very itchy. Varicella is one of the live attenuated viral vaccines, so just like all the live vaccines, it can cause a mild illness. Some children after receiving the varicella vaccine have a mild fever or a few vesicles. This vaccine was licensed in 1995, so when I was a kid I had chickenpox and so did every other kid, but that doesn't happen anymore because of this vaccine. The schedule is 2 dosages, one at 12 months and one at 4 years. And because you have to wait 4 years before the child is fully vaccinated, sometimes children are exposed before receiving both dosages. For example, they might be exposed to an adult who has herpes zoster. When that happens, what you do is administer post-exposure prophylaxis, which is really just to give the vaccine. If a child before 12 months of age is exposed to a person with varicella, they should get their first dose early. If a child is between 12 months and 4 years and hasn't received the second dose and they're exposed to a person with varicella, then they should get the second dose early. Once they've had 2 dosages, they're considered to be immune and there's no need for any post-exposure prophylaxis. The hepatitis A virus causes a self-limited hepatitis. Symptoms usually resolve in less than 6 months, and I talk about this in more detail in videos in the GI section. The hepatitis A vaccine, most formulations contain killed or inactivated hepatitis A viral particles. Now, hepatitis A is much more common outside the US. It's very common in Africa and parts of Asia, like I'm circling with my pen here. But there are enough cases in the United States in children that years ago it was recommended that this vaccine be added to the schedule and given at 1 year for the first dose. Okay, back to this slide. So we talked about the first group of vaccinations, which is really only one vaccine, that's hepatitis B, given at birth. And then we just talked about all the 1-year vaccines, which are MMR, varicella, and Hep A. Now we're going to talk about this big group in the middle, which is basically all the other childhood vaccines. They're all given at 2, 4, and 6 months, and then some of them require a booster dose later, like at 12 years, 15 months, or some even at 4 years of age. So this slide is a list of what I call the 2, 4, and 6 month vaccines. They're all given at 2, 4, and 6 months of age, and then most of them also require some booster doses later on in life. The DTP vaccine stands for diphtheria, tetanus, and acellular pertussis. And just like the MMR vaccine that we talked about before, this vaccine combines elements to decrease the number of shots. The vaccination schedule for diphtheria, tetanus, and pertussis is the same, so the vaccine elements for all 3 are combined into 1 shot. Corynebacterium diphtheriae is what causes diphtheria. The symptoms of diphtheria are pharyngitis with a gray-white membrane. This is a picture of what it looks like on the screen here. Systemic toxicity from diphtheria can cause cardiomyopathy and be life-threatening. And the diphtheria vaccine is a classic example of a toxoid vaccine. Clostridium tetani is the bacteria that causes tetanus. It produces a toxin that blocks inhibitory neurons. This leads to overactivity of muscles in the nervous system, causing muscle spasms. And the classic symptom is trismus or lockjaw, where you cannot move your jaw. And tetanus is another example of a toxoid vaccine. Bordetella pertussis is the bacteria that causes whooping cough. And the initial vaccines against pertussis developed in the early 1900s were made up of whole bacterial cells of pertussis that had been killed. This version of the vaccine caused children to have fever and drowsiness and sometimes anorexia, and there were rare cases of encephalopathy. Because of the problems with the killed whole cell vaccine, so-called acellular vaccines were developed in the 1990s. These vaccines are purified bacterial components and inactivated toxin, so they have elements of the bacteria, but they do not contain whole bacterial cells. As a result, they are better tolerated and have fewer side effects. So that's why the DTP vaccine has a little A in it to indicate that the acellular version of the pertussis vaccine is what's in DTP. There is one special contraindication to this vaccine, however, that you should know for your board exams, and that is encephalopathy. Even with the acellular version of the pertussis vaccine, there have still been rare cases of pertussis vaccine encephalopathy reported. They usually occur within 7 days of receiving vaccination. So if a child develops encephalopathy after their first or second dose of the DTP vaccine, they shouldn't receive any additional doses. And this is a special contraindication that only applies to the DTP vaccine, and it's because of the pertussis component of that vaccine. The HPV vaccine protects against Haemophilus influenza serotype B, which is called HPV. This is the bacteria that can cause meningitis and also pneumonia. It's also famous for causing epiglottitis, which can potentially be life-threatening. These children develop fever, sore throat, and stridor, and their airway can become cut off from inflammation of the epiglottis. It's a conjugate vaccine. It's made up of a polysaccharide found in the capsule of Haemophilus influenza which is conjugated to a protein carrier. The carrier is usually either tetanus toxoid or a protein complex from Neisseria meningitidis. The PCV13 vaccine protects against the bacteria Streptococcus pneumoniae. This bacteria causes lots of infections in children, including pneumonia and meningitis, also bacteremia and otitis media and others. It's a conjugate vaccine. The reason it has the number 13 in its name is because it contains polysaccharides from 13 serotypes of strep pneumoniae. These polysaccharides are conjugated to diphtheria toxoid. There is an adult vaccine against Streptococcus that has a different name. It's called PPSV23, and it gets its name because it contains 23 pneumococcal polysaccharides. This version of the pneumococcus vaccine does not elicit a good response in children under 2, so it's not used in children. Children always get the PCV13 vaccine. And you may know that people who lack a spleen are highly vulnerable to infection with Streptococcus pneumoniae because it's an encapsulated bacteria. So in asplenic patients, they receive both of these vaccines. IPV is the poliovirus vaccine. It prevents poliomyelitis. This is a picture of a girl who has polio. Years ago, children would get polio, develop a febrile illness, and then a few days later, they would lose the ability to walk because of involvement of their spinal cord. You may know the US President Franklin Roosevelt had polio, and that's why he couldn't walk. So we don't see polio anymore because of this vaccine, and IPV stands for Inactivated Polio Vaccine. This is also called the Salk vaccine, named for its creator. This vaccine is made through inactivation of wild-type poliovirus strains. They're treated with formalin, which kills the virus, but the viral proteins remain as antigens and elicit an immune response. There is another way you can vaccinate against poliovirus using an oral vaccine. This is called the Sabin vaccine. This isn't used in the United States, but it's used in developing countries. The oral vaccine contains a live attenuated virus. The virus is grown in cells that cause it to have mutations so that it is not as infectious as the wild-type virus. This version of the vaccine is easier to administer because children just drink it. However, it rarely causes vaccine-associated paralytic poliomyelitis, or VAP, which is a version of polio. It's uncommon, but it can happen with this vaccine. So in the US, we always use the injectable IPV, but in developing countries where it's hard to get people vaccinated, they will go out and have children drink the OPV so that they have protection against polio. Rotavirus causes gastroenteritis, which in some cases can be severe and life-threatening. The rotavirus vaccine is a live attenuated viral vaccine. In 2006, oral versions of this vaccine were developed, which are given as drops in a child's mouth, like what's shown on the screen here. There's one special contraindication to the rotavirus vaccine, and that's a history of intussusception. Intussusception is a rare disorder in children. It's a cause of bowel obstruction, and I talk about it in more detail in videos in the GI section. But there have been cases of fatal intussusception in children after receiving their second dose of rotavirus vaccine. And in all of these cases, the infant had intussusception after the first dose, and then they were given the second dose, and they had a fatal intussusception. So intussusception is rare, but in any child or baby who has had it and has recovered, you don't want to give them the rotavirus vaccine. So back to this slide, I'll finish this video by talking about these vaccines down here at the bottom. These are really in a class by themselves. Influenza is given every year, and these other vaccines are given as a first dose at 11 to 12 years of age. The influenza vaccine protects against the influenza A and B viruses, which cause the flu. The vaccines that are used for children are quadrivalent. They protect against 2 strains of influenza A and 2 strains of B. The vaccine, as you may know, is updated each year because the virus changes, so you need vaccination against new strains each year. And annually, the vaccine comes out and it contains the strains that are expected to cause the flu season in the fall and winter. And the influenza vaccine is given to children every year right before flu season, as long as the children are greater than or equal to 6 months of age. And you can remember this because vaccine influenza has the letters V and I in it, which are the Roman numerals for the number 6. There are 2 versions available in the US of the influenza vaccine. The standard vaccine is an inactivated or killed virus vaccine that's given by intramuscular injection. The only contraindication to this vaccine is a prior severe allergic reaction. The other version of the vaccine is a live attenuated flu vaccine. This was licensed in 2012, and its advantage is that it's given intranasally, like shown in this picture here. So for people who are afraid of needles and injections, this is an alternative option. There are, however, a lot of restrictions on who can receive the intranasal version. The patient has to be healthy and non-pregnant. They have to be ages 2 through 49. So on your board exams, you cannot give this to a little baby, and you cannot give this to a person who is 50 years of age or older. The live vaccine does not contain thimerosal, although it does contain residual amounts of egg protein, and we'll talk about why these two things matter for the flu vaccine in the next two slides. Thimerosal is a preservative used in multi-dose vials of the flu vaccine, and there are some patients who have an allergy to thimerosal. So one of the cautions of the influenza vaccine is that you can't use these multi-dose vials to give the vaccine to patients who are allergic to thimerosal. You can, however, use the single-dose vials because those do not have thimerosal. And then, as I mentioned on the last slide, the intranasal version of the flu vaccine also does not have thimerosal, so that's an option for patients who have an allergy. When I was in medical school, we had to ask patients if they had an allergy to eggs, and if they did, we didn't give them the flu vaccine. That's not the case anymore, and let me explain why this is so. So most flu vaccines are manufactured using eggs as a growth medium, and for this reason, within the flu vaccine solution, you can find small amounts of the egg protein ovalbumin. So years ago, it was thought that patients who had an allergy to eggs could react to ovalbumin and develop an allergic reaction to the flu vaccine. It turns out, however, that the amount of egg proteins is very, very low in modern vaccines because of the way they're manufactured. And clinical studies have shown that severe allergic reactions to the flu vaccine are incredibly unlikely, and patients are more likely to get ill from the flu than they are from a reaction to ovalbumin from eggs. So modern guidelines say patients with egg allergies can receive the influenza vaccine. There's no need for skin testing or special observation, and there's no need to screen patients before vaccinating them for egg allergies. Meningitis vaccines protect against the bacteria Neisseria meningitidis, which is one of the causes of bacterial meningitis. All of the meningitis vaccines are polysaccharide vaccines conjugated to a toxoid. They are made from the polysaccharides in the meningitis capsule. The vaccine that's given to children is the MACWY vaccine. It's called this because it's a quadrivalent vaccine that protects against serotypes A, C, W, and Y of Neisseria meningitidis. We don't give this vaccine to younger children, and that's because infection with Neisseria meningitidis requires colonization of the throat with this bacteria, and that doesn't occur until adolescence. So for this reason, the first dose is given at 11 years old, and the indication for this vaccine is all children 11 to 18 years old. Outside of this age range, it can also be given in special circumstances if patients are at high risk. For example, it's sometimes given to military recruits or people in a dorm where someone has come down with meningitis. And for your board exams, it's easy to remember that the first dose of meningitis vaccine is given at 11 years of age because the name Neisseria has two I's in it, which are just like two ones. There is another meningitis vaccine called the MenB vaccine. This is a monovalent vaccine that protects against serotype B, which is not covered by the traditional quadrivalent type vaccines. This is a newer vaccine, and it's really only used in niche special circumstances. The main indication is children 10 years of age or older who have a high risk of a meningitis infection. So this includes children with complement component deficiencies, children who are asplenic, either they are anatomically asplenic because their spleen's been removed, or functionally asplenic like children with sickle cell anemia. And then the other group is children who are exposed to meningitis in an outbreak. The HPV vaccine protects against human papillomavirus, which is a sexually transmitted infection. In women, it can cause cervical intraepithelial neoplasia and eventually cervical cancer. It can also cause anal cancer in both women and men. HPV serotypes 16 and 18 cause 70% of the cervical cancers worldwide and almost all of the anal cancers worldwide. And then types 6 and 11 are the types that cause anogenital warts. So the vaccine that's given for HPV is a 9-valent vaccine. It's been on the market in the US since 2016. It protects against all of these serotypes, which include 6 and 11, the two types that cause warts, and 16 and 18, the two types that cause most cervical cancers. And the ACIP, which is the Advisory Committee on Immunization Practices in the US, has guidelines that recommend that this vaccine be given to children at ages 11 to 12 years of age. It's a stronger recommendation for females, a 1A, a weaker recommendation for males. Now there's a special caveat to the dosing of the HPV vaccine that's high yield for your shelf exams and your board exams. If children begin their vaccination schedule for HPV before 15 years of age, at age 11 or 12 as is recommended, then they only need 2 doses, one dose at time 0 and a second dose at 6 to 12 months. But many children do not get the vaccine at age 11 or 12 for a variety of reasons, and they present later in life, often in their adolescent years when they're sexually active and they want to be vaccinated. If the vaccination schedule starts at age 15 or later, then you need to administer 3 doses, one at time 0, one at 2 months, and another one at 6 months. And it's very high yield to know this difference in dosing for your exams. The last vaccine we'll discuss in this video is the Tdap vaccine. Tdap stands for tetanus, diphtheria, and pertussis. And this is different from the DTP vaccine we talked about earlier, even though it protects against the same infections. What's different about Tdap is that it contains TD, not DT. TD is tetanus toxoid with a reduced diphtheria content. That's why it's got a lowercase d in it. And because it has less diphtheria content, it's used only as a booster, not as an initial vaccination. In children who have received the full series of DTP vaccines, at age 11 they need a booster, but the booster doesn't need as much diphtheria toxoid content, so there's less in Tdap, and that leads to less side effects. So if we go back to this slide, this is the DTP vaccine. It's one of the vaccines given at 2, 4, and 6 months. It's also given at 15 months and at age 4. The Tdap vaccine is down here. This is given as a one-time dose at age 11 to 12, and it's a booster with a lower content of diphtheria toxoid. You should also be aware that children and even adults who have puncture wounds after age 11 are given the TD vaccine. It doesn't have the pertussis component, it's just the tetanus and the diphtheria component. And this is given as a booster immunization to protect against tetanus. That's because puncture wounds can potentially lead to a tetanus infection. So if someone has a puncture wound after age 11 and it's been more than 10 years since their last tetanus immunization, then they are given the TD vaccine. I'll finish with one slide on premature or low birth weight babies. You don't need to delay or adjust the doses of vaccination for these babies, so don't get fooled by this on a board exam. If a baby is born 2 months premature, that baby should still receive all vaccines according to the chronological age of the baby, meaning at 0 months, 2 months, or 6 months of age. Premature babies get the normal schedule of vaccinations. The only exception is the first dose of hepatitis B. As we've discussed, that's normally given in the hospital at the time of birth. In premature babies, it's delayed until hospital discharge or 30 days of age, whichever is earlier. But outside of this one small exception, babies who are premature get the normal schedule of vaccinations. And that concludes our module on vaccinations.